There we go. Click OK there. Um, all right. So yes. My name is Brooke Yancey Ward, and I am a pediatric psychologist at UAMS in Arkansas Children's Hospital. And today we'll be talking about maternal and infant mental health, how a mother's mental health can have both short-term and long-term effects on her baby. Ways that caregivers can make a positive impact on their relationship with children, what attachment is and why it's important, as well as strategies that the research shows us can be really helpful for caregivers to thrive with their mental health and their self care. So this presentation really came from my own passion project and interest in working in the NICU and these parents and babies having a really special place in my heart with my work and what I do each day. And the information that we're going to talk about that's going to be presented today absolutely applies not only to families with babies who may be medically complex or who were born early, but to all parents with babies. So this is definitely, we'll talk about both things with the NICU and our preterm littlest babies, as well as general population as well. Um, so I have yet, oh, let's see here. There we go. I have yet another QR code for you all. So this is actually linked to an evaluation that you can complete for this presentation. So it will take you directly to the evaluation form that we actually use as part of UAMS in the Department of Pediatrics. So I will also include this same slide and QR code at the end of the presentation as well. And this is my first time giving this presentation. And so I would love to have your feedback and get your feedback with that. All right. And now going into our objectives for the day. So at the conclusion of this, you'll be able to recognize symptoms of clinical concern versus normative postpartum reactions, identify 3 ways that maternal depression can negatively impact a child's development, and list 2 ways that psychologists and mental health professionals can helpfully intervene through prevention and treatment. Okay. All right, so let's first talk about just some definitions of terms, some terminology that we'll use in reference today. So we're going to dive right in after that to facts and statistics that we know about parents' emotional reactions throughout the perinatal period. So first, I want to go back to these terms a little bit. So perinatal is going to refer to the time period during pregnancy and in the first year after birth. Prenatal is just during that pregnancy period, and then postpartum is going to be specifically after birth. So as far as just typical emotional reactions, kind of diving into that. So we know that among women, the leading cause of disease-related disability is depression. And about 15 to 21% of pregnant women experience moderate to severe symptoms of depression or anxiety. So that tells us that it affects quite a bit of our population. So now looking at parents' emotional reactions, particularly during the postpartum period, we know that about 10% of new dads or partners also experience depression, mood, or anxiety problems. The highest risk factor for a partner experiencing a mental health crisis is if the mom is experiencing emotional struggle. So I thought that has been really interesting since I first learned about this. So the highest risk factor for a dad or a partner experiencing any kind of emotional struggles, mental health struggles, is if the mom is experiencing that or any kind of emotional struggles. So diving into a little bit about the baby blues. So this is where we're kind of talking about what's normal, what can be expected versus clinical concern. So the baby blues. So this impacts about 60 to 80% of new moms. It is not a disorder, and moms still report feeling happy overall. They do not have suicidal ideation. They still have pleasure and joy in being a mom with an appropriate amount of worry that we would expect for a new mom. Symptoms of the baby blues include exhaustion, tearfulness, lability, and reactivity. The time frame here is going to be about 2 days to 2 weeks after birth, usually peaking around 3 to 5 days after delivery. So some of these things absolutely kind of goes into being a new mom, like exhaustion. Our new mamas probably aren't sleeping super well. They're going to have a labile mood, some different things going on because these hormones are just really going through a major, major shift at this time. Um, Symptoms can be similar to postpartum depression, but they are less intense. So, for example, moms with baby blues are a little bit more tearful rather than experiencing this extreme sadness. And baby blues, symptoms of the baby blues are not going to extend past 2 weeks postpartum. So remember our time frame here. Baby blues, 2 days to 2 weeks after birth. And then things that would be more of clinical concern is going to be extending past that 2 week mark. And we know also from the research how important it is for OBGYNs to be monitoring this at those postpartum checkups. And we'll get into a little bit more about that as well as far as screening and how to catch these mamas. So, specifically looking at research with preterm babies and experiences within the NICU, we know that when it comes to looking at and studying parents' emotional reactions, anxiety and depression are definitely prevalent after a preterm birth. So, this research helps us to know that we should be particularly aware of emotional reactions if we are working with families following a NICU admission. And beyond that, research has shown that NICU staff identified parents' emotional reactions and experiences such as anxiety, shock, loss of control, lack of feelings of being competent as a parent as highly prevalent. So NICU staff are noticing that parents are dealing with these really tough emotional responses. And interestingly, preterm infants' cues are more challenging for parents to respond to. And this can lead to it being a little bit more difficult for these mamas and these dads to form a relationship initially. It might be a little bit of a struggle there initially because of their baby's cues being a little bit more hard to respond to. And we'll talk more in this presentation as well about responding to our baby's cues and how parents can do that. We know that maternal and paternal traumatic experiences are linked to less sensitive interactions with those babies, differences in infant behavior long term at 18 months, and infant sleeping and feeding difficulties. NICU staff do definitely play a crucial role in supporting our parents. And NICU staff perceive the parents' emotional experiences as highly important, but don't have education or training about attachment and social emotional development. And this is where we as professionals working with early childhood populations or their families can really make a big impact simply by understanding these concepts and how to help these little ones thrive in their social emotional development and give parents tips, strategies, and general education about things they can do to support healthy, secure attachments and help these children thrive in all areas. So let's go through some of the most common perinatal mental health disorders that moms may struggle with. So starting with postpartum depression. So some symptoms are pretty similar to what we would expect for other major depressive episodes, but might differ a little bit as well. We'll talk about that. So they might experience feelings of anger or rage. They might be really fearful of what could happen to the baby, experiencing a lot of fear, having these worst case kind of catastrophizing thoughts, having a lack of interest in the baby, being unable to find pleasure in things they used to enjoy, extreme differences in appetite, being really, really hungry or not hungry at all, sleep disturbances, not feeling well rested, which again, that can be a little bit hard to parse out because we know that new mamas might be having a hard time sleeping simply because they are a new mama. Having difficulty making decisions, being really indecisive, or having really low self esteem. And then also, lastly, they might be having thoughts of harming the baby or themselves. They may have suicidal thoughts, plans, or intentions. And again, remember this, having the suicidal ideation is what's going to be a big key factor that differentiates this from the typical postpartum blues or baby blues. These symptoms are going to persist for 2 or more weeks after giving birth. And about 1 in 7 moms and 1 in 10 dads experience postpartum depression. And we'll talk a little bit more about dads as well later in the presentation. And an interesting fact found in the research is that low-income women and teenagers do have rates of postpartum depression of up to 60%. So these populations may be especially susceptible to experiencing this. Okay, so now I want to talk a little bit more about maternal depression specifically. So, depressive symptoms such as withdrawal, irritability, and disengagement, even low levels of these that do not meet criteria for formal diagnosis, can greatly impact a baby's development in emotional, social, behavioral, and then cognitive and developmental domains. And and these symptoms interrupt sensitivity and positive engagement between the mom, the caregiver, and the baby. 1 in 10 children are cared for by a depressed mother, and this can affect outcomes. And again, that's cognitive and emotional development, as well as behavior, health practices, social adaptation, access to healthcare, and home safety risk. We'll also talk about this a little bit more. And the American Academy of Pediatrics and the American Congress of Obstetricians and Gynecologists, or ACOG, if you are familiar with that, have actually called for postpartum depression screenings for all mothers from birth through age 1 because of the prevalence of postpartum depression and the negative impact that this can have on a baby's development. That's why these organizations are really calling for screening for these moms throughout that postpartum period. So again, just a little bit more about how mothers with depressive symptoms can affect their babies. They tend to be less involved with their children, and they might have a little bit more difficulty expressing positive reactions to their babies, less interaction, touch, and vocalization. And this can affect the baby's language acquisition if they're not being exposed to that language or that kind of back and forth cooing and babbling going on. It can also lead to minimal exposure to reading and reading together with our babies. They're more likely to ignore their child, become disengaged, and provide minimal comfort in response to stress. So again, they're not responding to their baby's cues like we would want. And they may also show more hostile parenting behavior, such as yelling. And that can come from stress, having low frustration tolerance. So we know that elevated safety risk can also occur more often for our mamas with any kind of depressive symptoms. And the things that might fall into this category of the safety risk are going to be things like inadequate supervision, poor implementation of safety rules, misuse of car seats, and then overall maltreatment. They may be less likely to breastfeed their babies. So this can actually lead to using things like water, juice, or cereal a little bit earlier than what would be recommended by a pediatrician. And early exposure to depressed mothers who engage in negative parenting practices can lead to an increased likelihood of internalizing symptoms, excuse me, like our anxiety or depression, as well as externalizing problems like aggression or rule breaking in the child. There is a possible correlation between maternal depression and suboptimal growth and developmental delays. And one of the theories in the research that could attribute to this is insufficient feeding. So if the mom is not responding well to their baby's hunger cues or just less involved, ignoring their child, they may not be feeding their child the way that we would want them to be, which can lead to those growth and developmental delays. All right. So for many mothers, pediatric visits are the only consistent contact with the healthcare system and healthcare professionals during their child's first years of life. And because of this, these visits are an optimal time and a great opportunity to implement regular screenings to assess maternal depression. Several screening options that vary in length, questions, and comprehensiveness do exist, like the Beck Depression Inventory, the Edinburgh Postnatal Depression Scale, which is very commonly used. And the choice that a clinical practice makes as to which measure they may use often depends on their resources and their goals of that measure and what they're wanting to do with follow up there. We can provide education about depression and its impact on children and the family by providing things like resources, whether that's educational handouts, community resources, support groups, outpatient counseling, and future steps mothers can take to help themselves and promote healthy development for their child are all things that we can kind of help with and intervene with there. All right. So now we'll talk about some other mental health disorders that can be prominent for our mamas during this perinatal time period. So starting with anxiety disorders. So the prevalence for prenatal anxiety, so before that baby is born, is about 15.8% in moms, and then a wide range here, anywhere between 4 to 16% in dads. And the prevalence for postpartum, so after the baby is born, anxiety is between 8 to 20% in moms and 2.4 to 18% in dads. And the variance in this prevalence rate is really because of the research that exists out there. And the research is having different methodologies, different sample sizes, things like that, that we kind of get quite a range here with the prevalence. So we're not exactly sure what might be the most accurate, but we know that it's somewhere within this range. And then looking at perinatal panic disorder. So we know that symptoms are more intense and have a faster onset compared to anxiety. There may not be an identifiable trigger for a panic attack. And we do know the three greatest fears are going to be a fear of dying, a fear of going crazy, or a fear of losing control. So next we're going to talk about OCD, or obsessive compulsive disorder. So with perinatal OCD, so remember this time period is going to be during pregnancy or the first year following birth. Symptoms include obsessions and compulsions related to the baby. So obsessions are going to be characterized as recurrent and persistent intrusive thoughts or images about harm to the baby that are unwanted and cause a lot of anxiety and distress in these mamas. So some examples of these obsessive thoughts or intrusive thoughts could be, what if I drop her? What if she dies? What if I accidentally hurt her? And the mother attempts to ignore or suppress the intrusive thoughts or images or neutralize them with some other thought or action. As far as compulsion, so these are going to be repetitive behaviors that the mother feels driven to perform in response to that obsession, like checking that the doors are locked, etc. Behaviors or mental acts are aimed at preventing or reducing the anxiety or the distress. So things like hand washing, counting. It is also important to remember that the mother is horrified by these thoughts. There's a lot of guilt and shame. And these symptoms feel very, very abnormal to the mom. This is not typical for her to be thinking or feeling this way. And I did want to mention too that exposure and response prevention is the gold standard treatment, and some specialized training is required for that. And on the right side of the slide, I have this visual of the vicious cycle of OCD. So one, we have that obsessive thought come in. Two, that obsessive thought leads to a lot of anxiety. We're then going to complete that compulsive behavior. And then four, we have a little bit of temporary relief with neutralizing or kind of combating, suppressing that anxiety or those intrusive thoughts or images. However, we know that cycle's just going to start all over again with that next obsessive thought that comes in. And I always tell families and people too that I work with that remembering that thoughts do not equal action. So those thoughts of, what if I accidentally hurt her? That does not mean that you're going to act on that thought or that that thought's going to come true. Okay, so this kind of leads us into talking about psychosis, and specifically perinatal psychosis. So this is where a parent is going to have delusional thoughts or beliefs about the baby. For example, that the baby is a demon or is evil. The onset usually occurs within the first 2 weeks after birth. And the prevalence, thankfully, is pretty low for this. So it's going to affect about 1 to 2 moms out of every 1,000 births. But importantly, this is why it's so critical to identify these mamas. About 5% do die by suicide, and 4.5% do commit infanticide or killing their baby. About 50% of first-time mothers who experience psychosis actually had no previous psychiatric hospitalization. So I don't say they didn't experience, some significant mental health struggles, but they didn't have any kind of inpatient hospitalization prior to the psychosis that was onset after delivering their baby. There are some important ways that we know from the research are really, really good at reducing the risk of this. So, for example, that's going to be remaining on any kind of prescribed medications or titrating down with close supervision by a qualified physician. And protecting good sleep is so essential. So, for these mamas, for this population, if we know they might be at high risk, we want to see they have some built-in support after the baby is born, whether it's a romantic partner or family, someone who kind of help watch the baby while that mama can get some sleep, to protect that sleep so she can get that. And we know that with an adequate treatment regimen, almost all mothers experiencing postpartum psychosis achieve full remission, and the majority achieve good functional recovery, which is very hopeful, very, very great findings that we've had in the research there. And I did also want to point out the differences here that are so key between psychosis versus OCD. So with OCD, the parent is going to recognize that their thoughts or images are unhealthy. They're going to have extreme anxiety related to those thoughts and images. There's insight into it, awareness, and distress about these thoughts or images. And the parent does not want to harm the baby. The parent has taken steps to protect the baby, and there are no delusions or hallucinations that are present related to harming the baby. Versus with psychosis, the parent may not recognize that these actions or thoughts are unhealthy. They may have minimal insight about the distortion of these thoughts. They don't have quite as much anxiety when they have these thoughts. They believe that the thoughts of harming the baby are reasonable or feel tempted to act on them. And there may be delusions or hallucinations going on. For example, voices telling them to kill the baby. So just some other perinatal mental health disorders. So we're going to dive in first to PTSD. So prenatal PTSD affects about 3.3% of mamas, postpartum PTSD, about 9% prevalence. And some possible traumatic perinatal events include things like emergency C-section, postpartum hemorrhage, prematurity, or having a baby that was stillborn, having an unexpected NICU admission, any kind of fetal anomaly diagnosis during pregnancy. Those can all contribute to some trauma that the mom may feel. And birth trauma is definitely, I'm sorry, is defined as an event occurring during the labor and birth process that can involve actual or threatened serious injury or death to the mother or her infant. And the mom may experience intense fear, helplessness, loss of control, and horror. And the prevalence of PTSD, specifically due to a birth trauma, is about 3%. So bipolar disorder is a chronic disorder. It has really high rates of relapse, suicide, and psychosocial dysfunction. And there can be peripartum onset of bipolar disorder. And remember that peripartum is going to be defined as during pregnancy or within the first 4 weeks of giving birth, according to the DSM. So the DSM-5 TR does have this specifier of peripartum onset. 50% of women with bipolar disorder are first diagnosed in the postpartum period, which is pretty interesting. And among women with a diagnosis of bipolar 1 disorder, 71% had reoccurrence during pregnancy, often in the first trimester. And women who stopped mood stabilizers had twice the risk of reoccurrence, which is 4 times more rapidly than women who continue their medication. So that's why it's so important that women stay on their medication with the close supervision of a qualified physician or titrating down, because we know that just cutting cold turkey, abrupt stopping of that medication can actually have more severe outcomes.
Excuse me. And Brooke, I forgot I didn't ask you about this earlier in terms of how
Yeah,
you wanted to handle questions. But we
yeah,
do have a question in the chat, and you feel free to let us know if you want to answer it now or later. But
yeah.
Mina and Don were wondering, do you know if there are any birth centers in Arkansas that offer support groups for new parents in general, mothers, fathers? Are you aware of that?
So unfortunately, I'm not aware of any support groups within Arkansas that are meeting. However, I know that at some hospitals that have NICUs, there may be some support groups that like social work could be doing, because we know that not all hospitals have psychology present in the NICU. But some NICU social workers might be having support groups, especially for NICU mamas. However, I do have another resource that we're going to talk about that has national support groups for moms, and that's going to be the PSI network. So we'll talk about them because they are a great, great resource. I love them so much. But they have online support groups across the country. So we'll talk about that. And they also have support groups for more specific things that might be affecting a mom. They have support groups for moms who are postpartum. They also have specific ones for mamas who have been in the NICU. So they have a lot of different subcategories, if you will, of support groups as well. That's a great question. So not that I know of, unfortunately. That is a really, really good question. I wish we had more because that's definitely something we could use at every birthing center, every hospital. And thank you for letting me know about that question too, because where I'm sharing my screen, I cannot see if there's a chat, it doesn't pop up for me. So please, at any
Right.
time, if y'all want to ask a question or stop me, you absolutely can do that.
Okay. Awesome. Well, it was just one other. Then somebody was just
Yeah,
wondering if they can get the slides. I think a couple of people actually are wondering
absolutely.
about that. Okay.
Yes,
Excellent.
definitely. I will send the slides after the presentation for sure.
Excellent. Thank you, Brooke.
All right. Yeah. So it's a little bit more about bipolar disorder. So we know that about 45 to 52% of women with bipolar 1 or 2 experience a relapse or exacerbation of symptoms during pregnancy. And about 70% of women with bipolar 1 or 2 relapse within the first 6 months postpartum. And that could be because of the additional stress, the hormones, it could be if they did titrate down that medication. So just things like that to be aware of as well with these relapse rates for these mamas. Okay, so I apologize. This slide has quite a bit going on, but I'm going to dive into to each one of these things. So I know that you are all familiar with ACEs, or adverse childhood experiences. And the study that was conducted with Kaiser Permanente and the CDC back in 1998. So the research has led to an abundance of findings, not only in that original study, but also in many follow-up studies that have been conducted since that time. And the findings have shown us the impact that ACEs have on health outcomes, both mental and physical health, as well as the impact these can have on a child's behavior. And experiences of adverse events in childhood has been shown to alter the molecular and genetic makeup of a child in the way that their neurological, immune, and endocrine systems develop and function. And we know that when one of these adverse childhood events is recognized in childhood, immediate early intervention is vital for the well being of these children. So on the right side of the slide, you can see a graph of the 10 original ACEs that were included in that Kaiser CDC study. There has been some research since that time that has looked at additional ACEs, such as living in a high crime neighborhood. But these original 10 include abuse as far as physical, emotional, sexual abuse, physical or emotional neglect, and then also some areas of household dysfunction, including mental illness of a caregiver, having an incarcerated relative, having a mother being treated violently or witnessing domestic violence on one's mom, substance abuse, as well as experiencing divorce. So when it comes to maternal ACEs that a mom has experienced in her life, there's been some really interesting findings related to this and NICU admission for their offspring, as well as adverse infant outcomes and perinatal complications. So, researchers found that mothers' ACE scores led to a significant risk for infant mental health outcomes over and above other known health risks during pregnancy, such as smoking, alcohol use, etc. Women reporting 6 or more ACEs had a 4 time greater odds of having an infant with adverse birth outcomes and 9 times greater odds of a NICU admission and 4 times greater odds of having pregnancy or birth complications. And higher ACE scores are associated with preterm birth, low birth weight, and maternal health risk during pregnancy. So, what could explain some of these findings? So the research discusses how these results support what is called a biological intergenerational transmission framework, which suggests that risk for maternal childhood adversity could be perpetuated in the next generation through biophysical and behavioral mechanisms during pregnancy that negatively affect infant health outcomes. We know that pregnancy and childbirth presents a unique, special, and extreme physiological challenge that could potentially activate underlying predispositions to inflammation and disease, especially when combined with stress. And this helps to also explain the increase of gestational new onset diseases such as hypertension or diabetes among women who are otherwise seemingly healthy prior to pregnancy. Another point, along with these ACEs scores, is that some research has suggested that the combination of adverse developmental environments or childhood exposure to stress like ACEs or experiences of racism among ethnic minority women, for example, are linked to epigenetic changes. And epigenetic refers to an interaction between genetics and the environment that can occur that actually alter physiological functioning and contribute to generational disease risk. So, taking everything together, exposure to biological and social stressors could be a key underlying factor leading to physiological changes and adaptations in later health trajectories. And it's also important to note that these authors' research findings suggest that the association between maternal ACEs and adverse outcomes are found at the highest levels of adversity. And they say that the level of adversity may need to be at the extreme in order to influence these types of outcomes, which is a protective factor for our mamas who have experienced adversity, but maybe not quite to this extreme. And these findings show us the importance of maternal screenings at clinic visits, such as those OBGYN appointments, prenatal visits there, or pediatric clinics after the birth of the baby. And so, my hope is that these moms can get referrals for their own counseling and therapy so that we can help reduce parental stress and other symptoms such as depression and anxiety and promote overall psychosocial well being for the mom and then potentially mitigate some of the possible adverse outcomes for the baby. All right. So I told you I would talk a little bit about dads. So I want to include a little information as well, specifically for them. And it is just a little information, unfortunately, because there's not a ton of research out there yet that focuses solely on fathers during the perinatal period. But we do know that there are some paternal perinatal hormone shifts, including a decrease in testosterone, an increase in cortisol, estrogen, and oxytocin. And researchers found that decreased testosterone in new fathers predicts depression at 2 months and 9 months postpartum when looking at follow up longitudinal studies. And we know that paternal depression is associated with increased negative parenting, such as or hostile behaviors, and decreased positive parenting behaviors like affection or showing support for their little one. And less than 50% are likely to report consistently reading to their 1 year old children and is associated with adverse childhood outcomes like an increased risk of developing depression by age 18. And less than 1 in 5 men in the US are offered paid paternity leave. Dove has actually launched the Pledge for Paternity Leave in 29. The Pledge for Paternity Leave is their cause, and this was launched in 2019. So they're really championing for paternity leave for dads worldwide, which is really cool. So now looking at some evidence-based approaches to help these populations and help these parents and caregivers. So we know that CBT is definitely really supported in the research, both individual and group therapy, as well as interpersonal therapy, both individual and group formats, peer support, whether that's in groups or telephone, or some kind of virtual platform, psychoeducation, as well as medication as indicated or warranted. So let's talk about what parents and caregivers can do to help manage the stress and anxiety that comes with taking care of children. So we'll first start with coping skills that the research tells us are effective and helpful. So first is behavior activation. So we want to encourage moms to get up and moving as they're able to and once they're medically ready after delivery. Whether it's dancing to music playlist, walking in the park with their little one in a stroller, walking their dog, hiking, taking exercise class, yoga, stretching, gardening, any of those things can all help release those feel-good hormones and chemicals and help reduce stress and anxiety. Second, it's good old deep breathing. Third is visual imagery. Fourth is positive affirmations. Fifth, mindfulness. And then sixth is this cognitive strategy of what would you tell a friend if they're going through something similar? How would you support them and be there for them? So those are just the ones that I use a lot with the mamas on our NICU. So now we're going to talk specifically about self-care. So first is just to get in some good laughter, and we can tell moms to let themselves just have fun and do things that they find joy in, whether that's reading, meeting up with friends if they're able to, being outside, engaging in hobbies, things like that. Research shows that 20 minutes of laughter or play can decrease stress symptoms by 50%. So that's definitely what I like to talk to mamas about. Second is writing down 1 to 3 things that they're grateful for each night before bed. So I explain to moms that this will help to literally train their brain to look for positive things throughout the day and help shift those thinking patterns to the healthier, to be healthier and happier. So we also talk about using their social support system, scheduling date nights with their partner, making sure that they're, prioritizing their relationship, their romantic relationship as well with each other. Watching a favorite feel good movie or TV show, doing adult coloring books. We have a lot of mamas that enjoy doing that in the hospital. Reading a new book that's just for fun. And then as best they can, always tell them this, try to prioritize that sleep each night, which again, we know that for mamas, it can be really tough early on. Making sure they're staying hydrated, just drinking some water throughout the day, eating good, nutritious meals throughout the day. Because for a lot of mamas, they just put themselves on the back burner. So they might go hours or a whole day without eating, without drinking much water, things like that, just kind of really running themselves down. And I also tell them, make sure you give yourself a lot of good self love, compassion, being gracious on yourself. You're learning, you're new at this. Even if you have had older children, again, you're still welcoming a whole new child into the family. And then also, of course, seeing a therapist, psychologist, or other licensed mental health professional as needed. And there are local providers across the country that can be found through the Postpartum Support International website. So I thought PSI Foundation, organization that I was talking about earlier, that is a great resource. And so they have a list of providers that have received extra training and certification in perinatal mental health, so specifically for these mamas. Um, and I went and got my own certification. So psychologists can absolutely, we can go and get this certification and training as well. And it's really, really great. Other things that can be really good for new moms might include a meeting with a pregnant or new mom support group, like someone had asked in the comments, asking a partner or friends and family to help with house chores, kind of divvying up the tasks. Or having a meal train or meal prep prior to delivery, just to have food ready on the go for them. All right. So now I want to move into talking about the concept of goodness of fit, which some of you may be very familiar with, and others may not have heard as much about this. So this concept describes the relationship between caregivers and children and how their relationship can have implications on a child's development and functioning. And one of the key components to this is a child's temperament. So we'll talk about that next. And it's also interesting because we'll see how things like maternal mental health can play a role in this idea of goodness of fit and child outcomes. So, what is temperament? So, I had a really fun time finding these baby photos online. So, we'll first talk about exactly what temperament is and how it's defined in the literature. And again, this may be some review for some of y'all, but not for others. So, we'll just kind of briefly go through some definitions here. All right. So, temperament is defined as an innate characteristic that is relatively stable across time and context. It emerges early and is biologically based. It's also characterized as these individual differences in reactivity as expressed at the emotional, attentional, and motor levels. And looking at these different levels of this reactivity, so we have negative affectivity, which is a child's tendency to react to new unpleasant situations with various negative emotions like fear, anger, or sadness, and they're pretty difficult to soothe. This idea of surgency or extroversion really gets at a child's level of sociability, their impulsivity and activity, positive anticipation for new or novel stimuli, and sensation seeking. Then there's this idea of effortful control. So this is the child's ability to focus their attention and inhibit inappropriate behaviors, and it includes executive control and their ability to delay gratification. Temperament is a robust predictor of adjustment problems and social competence. And researchers have also noted that there's significant evidence for a genetic influence in children's temperament, and that it's also possible that variations in hormonal or other factors in the prenatal period could also affect the nature of a newborn's temperament. But I haven't found anything in the research regarding specifics about what those prenatal factors could be. Because I thought that was interesting to say. Well, what can happen during pregnancy that can lead to differences in temperament? So I wasn't able to find that, but I thought that was an interesting thing. So as far as easy temperament, this is where a child shows a positive approach in response to new or novel stimuli. They quickly adapt to change, a preponderance of a positive mood, pretty regular sleep and feeding schedules. They smile at strangers. Overall, pretty happy. Difficult temperament, they might be more irregular in their biological functions like sleep or feeding, not really predictable with their routine, which you can see might be difficult on a parent. They can't really predict their day-to-day kind of routine versus a child with an easy temperament. um, More negative responses to new or novel situations or people, intense mood that's frequently negative, and having a lot more periods of just kind of loud crying, really difficult to soothe. Then the slow to warm up temperament is where there's negative responses of mild intensity to new or novel situations. They might slowly adapt though after kind of repeated contact and exposure. So they kind of gradually come to show a more positive interest and involvement. So not all individuals fit neatly into one of these three temperament patterns, and children who do fit one of these may show a wide range in the degree in which they manifest these general characteristics. I want to know that as well. Okay, so the goodness of fit model was first coined by researchers Thomas and Chess, and they're credited for first really coming up with this model. And this model proposes that when a child's characteristics, such as temperament, matches well with aspects of the environment, the child will gain adaptive benefits. And a good fit describes a relationship between parent and child, teacher and child, where where the child's temperament is consonant with the environment. So their temperament blends with the environment. It's parallel to it. And with goodness of fit, psychological development and functioning progresses in a favorable direction and leads to favorable outcomes. And then a poor fit describes those whose temperament is dissonant with the environment or is discordant or differing from the environment. So with poorness of fit, the child can experience excessive stress and failures of adaptation, and his or her development can then lead to less favorable outcomes. So Thomas and Cheth also noted in the research that goodness of fit doesn't imply that there's zero stress and conflict, but that the issue with poorness of fit and poor outcomes comes from excessive stress the child can't cope with, can't adapt to, or overcome. Research has also found that the neuroplasticity of the brain causes children to be highly sensitive to the level of support from their environment, especially during the first years of life. So, children's behavior and development are influenced by an interaction between a child's temperament and the environment. So, this can be a parent's behaviors, the teacher interactions that they experience. And we know that child characteristics such as temperament might shape or evoke parenting behaviors or teacher interactions. And in turn, parenting behaviors and teacher interactions might shape child temperament. And with this transaction between parenting and temperament, contributing to child adjustment and psychosocial outcomes. So, temperament may indirectly shape later child adjustment through parenting and teaching behaviors due to this transactional process. And some studies have found that a child's temperament may contribute slightly more to this interaction and trajectory than parent or environmental influences. Central to this concept is the idea that there's a bidirectional and interdependent association between children and their social context, having reciprocal effects over time. Specific dispositional traits can place children at greater risk for negative outcomes, especially when confronted with poor parenting and teacher interactions. And conversely, a child with these same traits could adapt very well with positive parenting and teacher interactions. So it can almost serve as like a buffer to those outcomes if they have that good environment with them. So parents and teachers can modulate the effects of a child's temperament by influencing their environment. The influence of children's temperament on the caregiver-child relationship quality may be mitigated if caregivers can adjust their caregiving behaviors to better fit the needs of the child. And responsive, warm, and authoritative caregivers can effectively buffer risk conferred by temperament. So these findings really demonstrate how parent and teacher responses, or that of any caregiver, are of paramount importance to prevent negative outcomes. And findings have also shown that certain traits, including difficult temperament, should be seen as plastic and malleable traits. And with positive caregiving, they can do very, very well and be on the path of a more pro social trajectory. So I think this gives us a really hopeful outlook as well to see that these traits can be malleable, that parents and teachers can have a positive impact on for sure. All right. So I want to just give as well some positive parenting tips from the CDC during the first year of life. So things like reading to the baby. So this can help them develop and understand language skills, sounds, singing to a baby, playing music. So this can help them develop a love for music and help with their brain development. Praising the baby, giving them lots of attention, mirroring back to them their coos, their smiles, that kind of interchange there, spending time cuddling and holding our baby, that positive physical touch. This will help them feel cared for and secure. Playing with the baby when they're alert and relaxed, and also making sure that we're watching for signs that the baby might be tired or fussy to kind of give them a little bit of that break from playing if they need it. Distracting the baby with toys, moving them to a safe area when they start to move or touch things that they shouldn't touch or that could be dangerous. Talking to baby. So babies we know can recognize their parents' voices after being born. So they will find those voices very calming. And then also answering when baby makes sounds by repeating the words and adding words. So this just helps them to learn and use language. So if the baby goes, ooh, ah, we can kind of say that back and then also add in a few more sounds or words as well. All right, so moving into attachment. So this can have similarities to goodness of fit, but it's also different and an entirely separate theory. So we'll see how the attachment relationship between caregivers and children also impacts long-term outcomes. So, what is attachment? So, it is a deep and enduring affectionate bond that connects one person to another across time and space. Both outgoing and shy children can be securely attached. And the type of attachment a child has is characterized by behaviors the child displays, like showing a preference for a caregiver, going to their caregiver when they feel threatened or upset, using the attachment figure as a secure base while exploring their world, feeling safe doing that. And these examples are consistent with a child who has a secure attachment. We'll talk about the types of attachment in just a minute as well. And then on the flip side, a child may display avoidance or resistance to a caregiver, not seek any comfort or contact with them, and overall display a lot of anxiety within the relationships they do if they do not have a secure and healthy attachment to their caregiver. All right, so adults can help to create a secure attachment by responding to the child's needs and cues, being consistent and reliable, and a source of comfort and safety. Attachment behaviors are remarkably similar across cultures, which I thought was also pretty interesting. Children are highly selective about attachment figures, so they're likely to attach to just a few caregivers. But this can include both family and non-family members, like teachers or childcare providers. And again, this might be a little bit of a review for a lot of you all, but just briefly going over the attachment styles. So secure, we see they have a healthy relationship with their primary caregiver. They show appropriate distress when they're alone. They can regulate their emotions pretty well. Ambivalent attachment, there might be limited parental availability. They have a lot more distress when left alone. They have a lot of feelings of anxiety and jealousy later on. The avoidant attachment style, they might have experienced abuse or neglect from their caregiver. They're more independent. There's a pattern of withdrawal, and they have more of a preference for casual relationships. They don't want to get too close to people once they get older. Disorganized is really marked by an inconsistent parenting style. They might feel really unworthy, and they might feel really confused in their intimate relationships and have a tendency towards more aggressive or antisocial behaviors. So, of course, as you all can see, and as we know, secure attachment is definitely the goal and what we want. It's associated with the absolute best possible outcomes for a child in a wide range of areas, including psychosocial, academic, relationship quality with family, friends, and romantic partners down the road, and overall mental health throughout their life. And there was a huge study done. So it's the NICHD study of early childcare. This was a comprehensive study of childcare and child development and looked at over 1,000 mother-child dyads. And data was collected over a span of 10 years and found that 62% of the dyads were found to have a secure attachment at 15 months old. There's also been promising findings across several research studies that secure attachment rates can actually increase during the preschool years and actually often do increase over time, with some findings indicating increases of up to 80% having secure attachments by the age of 4. And these findings have been attributed to increases in maternal sensitivity throughout the toddler years. So if a mom is really overwhelmed and disengaged during the early months after the baby's born, they might be able to adapt a little bit more, become more sensitive over time, and that baby can move to a more secure attachment, which is great. Also, research has found that the overall rates of secure attachments among mother-child dyads have been found to be consistent over time and relatively stable over the past 2 decades, illustrating that most children have a secure attachment with their primary caregivers, even if parenting practices change some over time throughout generations. In addition, a meta-analysis found that an individual's secure attachment pattern is very stable over time throughout their life. And disorganized attachments are much more malleable, which is great, positive news, and they can move to that secure attachment. Um, all right, I'm also watching my time. So, how do caregivers build a secure attachment with kids so they can be available and responsive? There is a book I love to always recommend by Dr. Daniel Siegel called The Power of Showing Up. He has some other books as well that are really, really great for parenting. Taking delight in their child, making them feel valued, validating the child's feelings, helping them learn emotion regulation strategies, being warm, nurturing, and attentive, reliable, and consistent, staying close to the child, but still allowing them some freedom to explore, encouraging that independence, and then also setting healthy limits and guidelines, making them feel safe, because we know that kids really thrive with structure and routine and having that predictability from day to day. Some of the long-term benefits of a secure attachment style include things like emotion regulation skills, cognitive development, problem-solving skills, showing empathy, social competence, overall being more resilient, being more trusting in relationships, and then also academic and occupational success. So now that we've talked and have some background information regarding babies and their parents, what can we do as psychologists who may be working with babies and families in one way or another? Well, the answer is a lot. So, in whatever capacity you might be in, you can help to identify signs for maternal depression, stress, or anxiety, and provide overall support for their caregiver well-being. Encouraging parents to have self-compassion and grace for themselves and getting lots of self-care as they're able to. And then I just wanted to throw out too that the standard of care for maternal screenings. So the American Academy of Pediatrics recommends to screen at 1, 2, 4, and 6 month visits. ACOG just has at least one time in the perinatal period, so a lot, less frequent there. And then PSI, so look at that organization that I like so much, has definitely the most thorough and comprehensive follow-up recommendations. And this is what our NICU at ACH and other places around Arkansas have put into practice. So at the first prenatal visit, second trimester, third trimester, 6 weeks postpartum, 6 months and 12 months postpartum, as well as at the 3, 9, and 12-month pediatric visits with the pediatrician. So this way, it's the most comprehensive so that wherever we can catch these moms, whether it's at their OBGYN, at the pediatrician's office, we can kind of help screen these mamas and make sure that we're capturing anyone who needs extra help. As far as some other resources that are available, so again, that Postpartum Support International, they have a tool to find local providers, like I said, resources for parents, online support groups. They also have a helpline. UAMS does have a women's mental health program. So it includes a multidisciplinary staff, including psychiatrists, social workers, and nurses. Um, They partner with perinatal care providers throughout the state to provide high quality care for women with neuropsychiatric disorders. And I know that UAMS, this Women's Mental Health Program, also has a 6 week program for postpartum mamas. That's really good. I've heard a lot of great things about it. And then HRSA, so the Health Resources and Services Administration, does have a maternal mental health hotline that provides 24/7 free confidential support, resources, and referrals to any pregnant or postpartum mama facing any kind of mental health struggles. So they also have a phone number there. All right. Okay. Watching my time. I just have some references. And then, yeah, so that is everything I have for today. Thank you all so much for attending my presentation.